Okay, thanks for that introduction, Elaine. I'm glad to be here giving this VAX talk to mainly a student audience and one faculty member. Two? Okay. I'm going to talk about cancer risk and prevention in people living with HIV/AIDS.
That's unfair. There are more faculty.
What's that?
That's unfair. There's more faculty.
Okay. Okay, so let me acknowledge up front my main collaborators. Leslie Park, Jan Tate, Amy Justice, Mike Silverberg, Lee Quinn, and Hai-Kyun Lin. Any research ventures these days are really done in groups. It's not really possible to do research on your own anymore. And there are many other people that should be acknowledged in terms of the work I'm going to describe couldn't have been done without them. Okay, so this is basically my seminar. So number one, cancer is a major cause of morbidity and mortality in people living with HIV/AIDS. People living with HIV have elevated risk for many cancer types, especially those with a viral etiology. And that's due to, number one, HIV infection itself, the effects of HIV infection. And number two, high prevalence of non-HIV cancer risk factors. Okay, and then thirdly, in terms of cancer prevention among people living with HIV, there are three main components. One is early antiretroviral therapy, or ART, to preserve and restore immune function. Second, reduction in prevalence of non-HIV cancer risk factors. And third, screening for selected cancer types. So that's basically it. But I'm gonna fill in the details in the remainder of the seminar. Okay, so first, cancer is a major cause of morbidity and mortality in people living with HIV. Let's first think about the general population. Cancer, as you're probably all aware, is a major cause of morbidity and mortality in the general population. And I'll focus on mortality. If we could demonstrate, a major mortality, kind of, knowing about cancer means there's also a lot of morbidity involved. So with this slide, I adapted from the latest data from the National Center for Health Statistics on mortality in the United States, which is from 2010. So this is proportionate mortality for three different causes: accidents, heart disease, and malignant neoplasms. And proportionate mortality is just the percent of all deaths. So for example, among people in the age group 15 to 24 years, more than 40% of deaths were due to accidents. Okay, so it's just asking, what are people dying from? It's not looking at rates, just saying, what are people dying from? So you can see that accidents are very important in the younger age groups, but kind of declines in importance, at least with regard to proportion of deaths. Cancer and heart disease, as you're all aware, aren't all that important, although in young people, although to some degree they are. But what I wanted to point out in particular is in this, this group, particularly from age 45 to 74, let's call it middle age, cancer is the main cause of death. It's not usually appreciated. If we look at all ages, heart disease beats out cancer by a bit, although cancer has kind of been moving up and will probably surpass heart disease within the next 5 years or so. But if you look at 55 to 64 and 65 to 74 in particular, more than a third of deaths in those important age groups are due to cancer. Okay, so cancer is clearly a major cause of mortality in the general population. Now, what about in the HIV population? Well, first, let's take a little digression And there's a kind of a classical classification system for cancer and HIV. We have our AIDS-defining cancers, which we'll call ADC for short. And those are Kaposi's sarcoma, non-Hodgkin's lymphoma, and invasive cervical cancer. And then all of the other cancers are non-AIDS defining cancers. Okay. I'm just curious, how many of you are familiar with the natural history of HIV? Okay, most of you. So I'll go through this fairly quickly. Okay, so we have primary infection, this point here, someone actually becomes infected with HIV initially. This axis shows CD4 lymphocyte counts. Okay, so that's this. This axis shows HIV RNA copies per milliliter in the blood on a log scale. So that's this. So initially, we have a big drop in CD4, a big rise in HIV RNA. But then the immune system kicks in and is able to control the HIV to some degree. So we see a drop in the HIV RNA, some recovery in CD4. Then we see a long period, might range from 8 to 12 years, let's say, where someone's infected but pretty much totally asymptomatic. It's a silent infection. And then eventually the immune system starts losing the struggle with the virus. And so virus increases, CD4 decreases, and at a certain point, we have the end stage of HIV disease, which is AIDS, as you all know. And in the absence of treatment with ART, once a person develops AIDS, their life expectancy is probably a year or two. Okay. So we could define AIDS as HIV seropositivity and either a CD4 cell count less than 200 or one or more AIDS-defining conditions, which the CDC has established. And we could put those into three categories: opportunistic infections, cancers, and other. I couldn't figure out anything else to call them. And in the pre-ART era, most people living with HIV died of AIDS. That was the cause of death. They might have died of a car accident, before they could die of AIDS, but generally it would be AIDS. All right, so just real quickly then, the AIDS-defining conditions. So let's dispose of the other first. So those are the other. Then we have our opportunistic infections. I'm just showing these briefly. So there are a bunch of opportunistic infections, specific ones that are considered AIDS-defining. As you know, fungus infections, there are viral infections, bacterial infections, protozoal, like all could be opportunistic infections. Okay, and then we have our AIDS-defining cancers. As I mentioned earlier, there are 3 of them. And it so happens that each one of them is caused by a virus. So KS is caused by KS-associated herpes virus, which we'll call KSHV. Non-Hodgkin's lymphoma, the subtypes that are particularly associated with HIV are caused by Epstein-Barr virus, or EBV. And invasive cervical cancer is caused by human papillomavirus, HPV. Okay, so those are our AIDS-defining cancers. So in terms of cause of death, in the ART era, we've seen a pretty dramatic shift. So in the pre-ART era, pretty much everyone's dying of AIDS. Now we're seeing a substantial increase in life expectancy, an increase in non-AIDS comorbidities, heart disease, kidney disease, liver disease, and cancer, and therefore a shift in the cause of death spectrum towards non-AIDS defining causes, including the non-AIDS defining cancers. Okay. So now let me show some of our data. This is from the Veterans Aging Cohort Study, also known as VAX. Amy Justice is the PI of that cohort, which is based at the West Haven VA. But it's a national cohort, as I'll explain in a minute. And I'm going to talk in particular about the VAX virtual cohort. It's totally assembled from national VA databases. There's no contact with patients. So this is all of the cohort includes all people in the VA medical system for HIV care. Okay, so it's a large cohort. The linkage among the databases is accomplished because there's a personal identifier, which is the scrambled Social Security number. So we have pharmacy databases, laboratory results databases, cancer registry, as I'll mention later, inpatient encounter database, outpatient encounter. And so all those could be linked together, and then you could follow these people electronically. Again, there's no contact, but everything's done electronically. And the cohort's periodically updated. Right now, there are approximately 48,000 HIV infected and 96,000 HIV uninfected. Whoops, this should have said uninfected. Matched to the infected by age, sex, race, ethnicity, and VA site. Okay. Okay, so we looked at time trends in cancer mortality among men in the VAX-virtual cohort. The reason we restricted it to men is that 98% of the cohort is men. And so we did this by linking VAX with the National Death Index, from which you could obtain cause of death from the death certificate. So this gives you the cause of death information on the death certificates. Median observation time was 6.4 years for the infected, 8.3 years for the uninfected, and there were a total of over 27,000 deaths in the cohort that occurred between 1996 and 2009. Okay. So first, simply look at time trends in cancer to proportion mortality. So HIV uninfected, HIV infected, 4 different time periods. And we're looking at the proportion of deaths that were from cancer. Okay, so you can see for the uninfected, it was fairly stable, around 25% across the periods. But for the infected, we see a rise in the proportion of deaths from cancer, from about a little over 15% to about 23.5%. Okay, now if we look at the AIDS-defining cancers in particular, we see that proportion of mortality is fairly low for the HIV uninfected. For the HIV infected, we see a drop over this time period from about over 7% to about 3.5%. So it drops in half for the AIDS-defining cancers in terms of proportion of deaths. Okay, and then the non-AIDS-defining cancers, again, fairly stable in the uninfected. See a rise from about 7.5% of deaths to about 18% of deaths during this time period. Okay, now what about mortality? Rates. We were just looking at, so far we've just been looking at the proportion of deaths from cancer. That tells us nothing about mortality rates. So now this is looking at cancer mortality rates, age and race, ethnicity standardized over these 4 periods. HIV infected, HIV uninfected. So it's cancer deaths per 100,000 person years. Okay. And you can see that throughout, the infected have a higher rate than the uninfected. Okay, then this is the AIDS-defining cancers. Very low rate for the uninfected, decreasing for the infected, as we would expect during the ART era. And then the non-AIDS-defining cancers, still higher in the infected than in the uninfected. Okay, so what are the basic conclusions from this? So cancer proportion mortality among people living with HIV is approaching that in the HIV uninfected population. It was still somewhat lower, but it was approaching. And cancer mortality rates are about 1.7-fold higher in HIV-infected persons compared to HIV uninfected persons. Okay, so we're seeing higher cancer mortality rates in HIV infected. Okay, so the next point. People living with HIV have elevated risk for many cancer types, especially those with a viral etiology. Okay. Okay, so this, I'm going to present more results from the VAX virtual cohort. So we're looking at, so far we looked at just looking at deaths, mortality. So now we're going to look at cancer incidence. So to do this, we linked, and this is work that I've done with Leslie Park, who's in the audience. We linked VAX with the VA Central Cancer Registry to obtain cancer diagnoses. So the VA has basically a national cancer registry that attempts to register every single cancer case that's diagnosed or treated in the VA system. And then we calculated age, sex, race, ethnicity, and calendar period standardized incidence rate ratios for HIV infected versus HIV uninfected. Okay, so I'm going to just present some of these incidence rate ratios. So first of all, and I highlighted in green the ones that were statistically significant, meaning the 95% confidence interval excluded 1.0. So for all cancers combined, the incidence rate was about twofold higher for the HIV infected compared to the HIV uninfected. Okay. Now, in terms of individual cancer types, oral cavity and pharynx was somewhat elevated in IRR of 1.3. That's a certain portion of those are related to human papillomavirus, as a lot of you probably know. Okay, anal cancer, a very high IRR of 28, also related to human papillomavirus. Liver cancer, 3.27, both hepatitis C virus and hepatitis B virus. Lung, no known viral etiology, but can anyone guess why lung cancer might be elevated, particularly in HIV-infected people? Yeah, as we'll see later, there's a high prevalence of smoking among HIV-infected. Although it's a little bit of a side, but it actually looks like the high prevalence of smoking is one of the reasons, but that immunodeficiency is an independent risk factor for lung cancer. The reason not being totally clear, as it's more clear for the viral infections. Okay. Right, melanoma, about a twofold elevated risk, no known viral etiology. Testicular cancer, we see this in our data. A number of cohorts have looked at cancer risk in HIV infected, looking at infected versus uninfected. Testicular isn't always seen, but most of the ones that I've talked about so far are pretty consistent with the literature. Then Hodgkin's lymphoma, pretty high of IRR of 9. That's related to Epstein-Barr virus. We know about NHL, I already talked about, and KS, IRR of 519. So KS is extremely rare in people who aren't infected with HIV. So this is, a huge incident rate ratio. And then leukemia, there are some leukemias that could be related to, that could have viral etiologies. Okay, so the conclusions from this part. So overall cancer incidence is about twofold higher in infected compared to uninfected veterans, right? Not surprisingly, people living with HIV have elevated incidence of AIDS-defining cancers. But also, there's elevated incidence of a variety of non-AIDS-defining cancer types, many of which have viral etiologies. Okay. So this is something that, this is well appreciated now, but it's something that didn't become appreciated until probably between around 2005 or so. Like, people used to think, okay, it's just those 3 AIDS-defining cancers that are an issue for HIV-infected people. But it turns out that there are some that are very high, like the anal cancer, Hodgkin's lymphoma, And lung cancer, even though it's only a twofold relative risk, lung cancer is so common that a twofold relative risk is really important in terms of public health impact. All right. Okay, so now we're going to go on and look at in more detail about reasons for why we see increased risk. So first, HIV infection itself. Okay, little diversion first. So some of you may not be aware that apart from HIV, the immune system is very important in cancer for two reasons, or probably maybe more than two reasons. But one reason is that it clears or suppresses oncogenic virus infections. And secondly, there's this phenomenon that was proposed a number of decades ago, and it became out of favor, but now it's more in favor again, of cancer immunosurveillance, meaning that that we're developing nascent cancer cells in our bodies all the time, which the immune system largely takes care of if it's functioning well. Okay, so those are at least two ways in which the immune system protects against cancer. But there's this other phenomenon that chronic immune activation and inflammation actually promotes cancer development, and that's pretty well established. And so the immune system's role in cancer is kind of complicated. On the one hand, it's protecting. On the other hand, if there's an inflammatory process and immune activation, it could be promoting cancer. All right. All right, so now I'm going to show you some results briefly from what was a seminal meta-analysis that I and my group had nothing to do with. I'm presenting this as an important paper that was published in 2007 in Lancet. And so they looked at cancer incidence in people with HIV and compared that with people who were immunosuppressed because they were organ transplant recipients, so who are routinely immunosuppressed, so they don't reject the transplant. So their reasoning was that the lifestyle-related risk factors probably differ substantially between those two groups. Like, for example, we know that, as I've already mentioned, that HIV-infected people tend to have a high prevalence of smoking. Not necessarily true of transplant patients. But the one thing that they had in common is the immunodeficiency. Okay, so they reasoned, okay, if we see a common kind of pattern of cancer incidence in these two immunosuppressed groups, it's likely that the reason for that is the immunodeficiency. So this was a meta-analysis. So they had actually I'll show the number on the next slide. They had 7 HIV/AIDS cohorts and 5 transplant cohorts. Each of the cohorts was what's called, in each of the cohorts they calculated what are called standardized incidence ratios, which is comparing the rate of cancer, a particular cancer type in the cohort with that in the general population. Okay, so one's able to get general population rates from cancer registries, and that's generally how they did this kind of study. Okay, so there were 7 HIV/AIDS, 5 transplant studies in this meta-analysis. Cohort size in aggregate was much larger for HIV/AIDS than for the transplant. Pretty much, virtually all of the transplant patients were renal transplant patients. All right. So here this is kind of my summary of their results. So let's walk through this. So these are cancer types that had a significantly elevated standardized incidence ratio, which you could look at as it's just another type of relative risk. It's the relative risk in the cohort compared to the general population. Okay, so for KS and non-Hodgkin's lymphoma, both in the HIV/AIDS cohorts and in the transplant cohorts, the SIR was greater than 8. So it's not surprising for the HIV/AIDS. We already know that those are AIDS-defining cancers, but that you see the same thing in transplant recipients. So a very similar pattern. Both greater than 4 for Hodgkin's lymphoma, anus, vulva and vagina, penis, non-melanoma skin. So I put in parentheses the virus that either is known to cause these types of cancer or is suspected of causing them. So for non-melanoma skin, for example, one of the main types of non-melanoma skin is squamous cell carcinoma of the skin. And it's not proven, but there's evidence linking squamous cell carcinoma of the skin to HPV virus, at least for a portion of those. Okay, then both greater than 2. We have liver, cervix, oral cavity and pharynx, lip, larynx, eye, lung, multiple myeloma, and leukemia. And both greater than 1.5, we have esophagus, stomach. H. pylori is a type of bacteria that's known to cause stomach cancer, and kidney. But all the rest of these are viruses. And then finally, both greater than 1.2, melanoma. So that's basically a summary of the Grulich article. And the conclusions we might draw are many cancer types had increased incidence in both groups. Most are known or suspected viral etiology. I didn't show this, but they saw in each of these groups, there was no increase in breast cancer or in prostate cancer, okay? Now, you might have thought there might have been an increased incidence of those cancers in these groups because they're both under very close medical surveillance, right? They're in the medical system, seeing doctors, more likely to be screened, therefore more likely for the cancers to be diagnosed. The fact that they weren't suggests that we can't explain the other increases that we're seeing based on medical surveillance. So according to the reasoning I showed in the beginning, when I started talking about this, the most likely explanation for the elevated risk of these many cancer types is immunodeficiency in these two groups. Okay, so now I'm going to show a little more of our own data. So some simple measures of immune function in HIV infection. One, of course, is CD4 cell count, which is kind of that's what the virus attacks. That's why there's immune deficiency, because of the lowered CD4 cell counts. And then secondly, HIV viral load. That's looking at HIV RNA copies in the blood. And that's actually a rough measure of chronic immune activation and inflammation. It's not perfect, but it's something to look at. All right. So I'm going to show some results on CD4 and HIV RNA in relation to KS risk in the North American AIDS Cohort Collaboration on Research and Design, known as NA Accord. Okay. So this is a big cohort collaboration. VAX is actually a member of this cohort collaboration. Consists of more than 20 HIV cohorts. The NA Accord got a lot of money back in 2009 from ARA to validate cancer diagnoses in all of these cohorts. So they were validated either by chart review or by cancer registry linkage. So these are good data about cancer. And then the NA Accord Data Center, which is located in Johns Hopkins, does a lot of work to kind of harmonize the data from these more than 20 cohorts into a single data set, which is a lot of work because people collect data in different ways and variables are defined differently, so you have to kind of sort all that out. Okay, so in this particular analysis, there were 15 cohorts that contributed data. Total N was almost 65,000. Among that N, these are all HIV, everyone in this cohort is HIV infected. 689 KS cases arose over a median follow-up of 6.2 years. Okay. We calculated hazard ratios using Cox proportional hazards models. Hazard ratios are the same as incidence rate ratios. So just think of them again as a relative risk. These models were adjusted for age, sex, race, ethnicity, cohort, calendar period of entry into the cohort, HIV risk group, such as injection drug use, et cetera, and baseline ART. All right. So this is looking at baseline CD4 in relation to KS risk. Baseline CD4 is the CD4 count at entry into the cohort. And then we're looking at that as a predictor of future KS risk. So these are our hazard ratios. Our reference group is 500 plus CD4 cell count, looking at different CD4 categories. So is this, does this impress you that CD4 count is a really strong predictor of KS risk? Just curious if you think this is impressive. Okay, no one wants to commit. Well, so I don't think it's very impressive, right? But there's so let's think about it. Is there another way we could look at CD4 count? This is just looking at taking a single CD4 count at baseline and then saying, okay, no matter how far we forward that forward, does that predict KS risk? Another way to look at it is to have our exposure of interest be the CD4 count 6 months previously. So in other words, we keep, as you follow the cohort forward, you keep time updating the CD4 count to use the CD4 count that occurred 6 months in the past. Okay, so when we do the analysis that way, this is what it looks like. So this is impressive. When you start seeing hazard ratios of 45, that's a pretty high risk. And so wanted to show these data, but also make the point that it's important to think about, how you define your exposure. Now, we did the same thing. We looked at baseline HIV RNA in relation to KS risk, so where less than 500 was our reference category. 100,000 plus was our highest category. Again, not real impressive. But then we did the time-updated HIV RNA. And again, now we're seeing much more impressive hazard ratios. Okay, so then the next thing we did was wanted to ask, okay, these are in separate models. So this is a model with HIV RNA adjusting for the factors, adjusting for these factors. But it didn't have CD4 count in the model. And this model didn't have HIV RNA in the model. Okay, so now let's put them together simultaneously in the same model, adjusting for all those risk factors. And so we can see that there's some mutual confounding, but we're still seeing pretty strong independent effects of CD4 count and HIV RNA. So in our less than 50 category, we're seeing a hazard ratio of almost 20, and our 100,000 plus HIV RNA category, we're seeing a hazard ratio of almost 10. So another way of looking at that, there being independent risk factors. If someone has a CD4 less than 50 and also has HIV RNA greater than 100,000, their risk would be about, let's say, 20 times 10, or they'd have a hazard ratio of about 200. Okay, so they're independent risk factors. Okay, so conclusions from this. Well, I already made this conclusion. Time-updated measures of CD4 and HIV RNA must be used to assess these covariates in relation to risk of KS, and by implication of other cancer types as well. And both recent CD4 count and recent HIV RNA level were strong independent predictors of KS risk. Okay, so that's not too surprising. So if we go back to this natural history here, so we know that, so KS is an AIDS-defining cancer. And that's in the period when our HIV RNA is going up, period of AIDS, and our CD4 counts are going way down. So this is why it's an AIDS-defining cancer. It's pretty clear based on the data that I just showed. Okay, so another study, this was a study that I was involved in that Michael Silverberg at Kaiser led. So this is Kaiser Permanente in Northern California. So they have a big HIV cohort. And in this particular study, there were more than 20,000 HIV infected and 10 times that amount of HIV uninfected. These are our mean observation times for this particular study. In this study, we calculated rate ratios from Poisson regression. So often Poisson models and Cox models, actually you'll get exactly the same results. So Mike really likes Poisson models, so I like Cox models better, but he was the leader on this, so we used the Poisson models. But this gives us rate ratios. And we did time-updated measures, again, 6-month lag, and adjusted for these various factors, including some cancer risk factors like smoking, overweight, obesity, and alcohol use. Okay, and just to briefly summarize these data, so this is with mutual adjustment of HIV, RNA, and CD4, as well as adjusting for the covariates listed on the previous slide. So we see for HIV, RNA, and this is risk for different selected cancer types, all non-AIDS defining cancers. So for HIV RNA, we're looking at greater or equal to 10,000 versus less than 500 copies. And you can see there's really not much going on here. So none of these results were statistically significant. For CD4 count, less than or equal to 200 versus 500 plus, we're seeing elevated rate ratios for anal, Hodgkin's lymphoma, oral cavity, pharynx, liver, not prostate, lung is kind of borderline, and colorectal. So seeing it for a number of different, this didn't look at like every cancer type comprehensively. Mike wanted to look at selected cancer types in this particular paper. So, but most of them are related to low CD4 count. Okay, so that's basically what this says. That low recent CD4 count was associated with increased risk of a variety of non-AIDS defining cancers. And there was no compelling evidence that high recent HIV RNA is independently associated with risk of non-AIDS defining cancers. Now this is one study. There's some other studies that do implicate HIV RNA, at least in some non-AIDS defining cancers. Yeah.
On that last study, the colorectal cancer, the odds ratio was quite high.
Yeah, that's interesting. Okay, so you wouldn't have necessarily. So we're seeing this for colorectal cancer, which you wouldn't have necessarily expected because. So there are a few possibilities. One is just that it's, random, just a random finding that doesn't mean anything. Because most studies have not found colorectal cancer to be elevated among HIV-infected people. Another possibility, which I think is intriguing, so I've been focusing on the aspect of the immune system that suppresses viral infections, and therefore, in HIV infection, the virus-associated cancers have elevated risk. Now, a cancer like colorectal cancer or breast or prostate cancer, they develop over many, many years, decades. And the way that they would be related, could be related to HIV, are number one, the inflammation, because those cancers, there's good evidence that that inflammation does increase the risk of those cancers, including colorectal. And secondly is the cancer immunosurveillance. And if that, so if that's a way that the body normally controls colorectal cancer over the long run, if that's impaired over the long run, we might see an elevated risk for colorectal cancer, which maybe maybe is just starting to emerge or hasn't emerged yet because we're only less than 2 decades really into the antiretroviral therapy era, right? So that's one of the things that I think people want to look for. Will these other cancers start emerging as being elevated? Yeah, but this is just one study, so it's hard to really say. Okay, so next, high prevalence of non-HIV cancer risk factors. So what are we talking about here? So I listed modifiable cancer risk factors and cancer sites to which they're known to be associated. So I didn't actually, in this one, I didn't list suspected, just known. Yeah.
You know, I was wondering when you were comparing in the VAX cohort between the infected and non-infected, would the HIV-infected people tend to live in urban areas where certain risk factors for like lung cancer would be more elevated?
So they're matched on VA site, though. Yeah, so that's pretty much taken care of. Yeah, so like if it's the New York VA, then the HIV uninfected are coming from New York VA. Okay, so as you know, smoking, about 30% of overall cancer deaths are due to smoking, so that's the really big one. But alcohol is a risk factor for these cancers, well established. Obesity, and we've already talked about viral infections. And so what I've listed here is, so this is prevalence of some of these risk factors in the general population compared to persons living with HIV. So, and this, so these are ranges, because obviously people living with HIV are, are a heterogeneous group. And these ranges come from different recent studies that have looked at prevalence of various risk factors. But the smoking is really striking, because even the lowest one is twice as high as the general population. And then there are some groups of people living with HIV with extremely high smoking prevalence, mainly injection drug users, actually. Okay, alcohol is kind of difficult to figure out because there are so many different measures that are used in different studies of hazardous alcohol consumption, but I listed it because it is an important risk factor. And the thinking is that overall alcohol consumption is higher among people living with HIV, especially injection drug users. Okay, obesity is one where actually the prevalence is lower, although since the advent of ART, it's kind of been coming up in HIV infected because we no longer have, the HIV wasting syndrome, which would do the opposite, is now much better controlled. Cervical HPV is pretty common in the general population of women, but it's definitely higher among people living with HIV. Anal, couldn't find anything about the overall general population. Men who have sex with men have a high prevalence of anal HPV, but even higher in people living with HIV. Oral, general population, 4 to 10%, 20 to 47% in HIV infected. And then also higher prevalence of hepatitis B virus and of hepatitis C virus infections. HCV is extremely high in injection drug users because that's a very easy way to transmit it. All right. So the point is that there is a high prevalence of non-HIV cancer risk factors overall among people living with HIV. Okay, so now the final point that I'll make in the last 5 minutes or so is approaches to cancer prevention, which I listed earlier: early ART, reduction in the prevalence of these cancer risk factors, and screening. So let's go through those briefly. So does early ART reduce cancer risk? So the only way to really prove that it does would be to conduct a randomized trial where you randomize people to have early ART or later ART and then compared cancer incidence. But that's not going to happen. So we have to go by other arguments. So first, biological evidence, what the known effects of ART. We know that it suppresses viral load, increases CD4 count, and that it reduces immune activation and inflammation. So we could kind of, make that jump. Well, okay, that means if our CD4 counts are improving, then we're probably doing better with regard to cancer. Secondly, there is increasing evidence from observational epidemiology that early ART will reduce cancer risk. As I said, there's no randomized evidence with regard to this question. But also, the question is an academic question because, at least in the United States, at least, it's already recommended that people start ART as early as possible. Now, that's something that's evolved over the last few years. It wasn't always the case because there are some downsides to taking ART, the toxicity, et cetera. But the current recommendation, so for those with high CD4 cell counts, this is quoting from the panel that makes the recommendations, whose short-term risk of death may be low, the recommendation to initiate ART is based on growing evidence that untreated HIV infection or uncontrolled viremia is associated with development of non-AIDS defining diseases, including cardiovascular disease, kidney disease, liver disease, neurologic complications, and malignancies. That's my emphasis. Furthermore, newer ART regimens are more effective, more convenient, and better tolerated than regimens used in the past. So the judgment of the panel is that to control these non-AIDS conditions, it's important to start ART as early as possible, which gets into a lot of issues about the importance of, early diagnosis, that it's not, a lot of people still aren't diagnosed with HIV infection until they start developing opportunistic infections, which is late in the game. So in any event, early ART is the odds are that it's very important in cancer prevention, although the only way to prove it would be with a randomized study. Okay, secondly, reduction in prevalence of non-HIV cancer risk factors. So there's people who are interested in behavioral approach, interventions in HIV, and people living with HIV might think about this because there's a lot of work that needs to be done in terms of targeted interventions. So it's not, for a number of reasons. If you think about smoking cessation, it's not that easy for anyone to stop smoking because nicotine is so addictive. But then on top of that, you have co-occurrence of alcohol use. You could have co-occurrence of drug use. It just becomes very difficult problem. But it's important, not just, smoking cessation is important not just for cancer, but as you know, it's an important risk factor for non-malignant respiratory disease, for heart disease, and for other conditions. So targeted interventions, particularly for smoking, I think, would be really helpful. So I kind of mentioned that. And then vaccination, certainly it's already recommended that HIV-infected people be vaccinated against HPV virus if they're not already infected with the virus. There's some evidence that vaccination might be helpful against HPV, even if you've had even if you've been infected previously. That needs a lot more work. So there's opportunities, actually, for people interested in behavioral interventions. The vaccination one is also very important. There's the issue of adherence because both of those require 3 vaccinations. So people are going to come back for the second and third. There are issues of efficacy because of the immunodeficiency, how well the vaccination is really going to work. That's not a behavioral issue, but the adherence is. And then treatment of HPV and HCV. So with HCV in particular, historically the treatment has been really bad, abysmal in terms of uptake and result. Just very, treatments are somewhat toxic. They take a long time. But a year or two, there was 2 new drugs were approved, and there are several other important new drugs in the pipeline that are expected to revolutionize treatment of HCV. And so that's something to really look for in the next next 5 years or so. And that could be really important for HIV-infected persons to try to clear HCV. All right. And then finally, cancer screening. So if people with people with a sufficient life expectancy, it's pretty clear that cervical cancer, breast cancer, and colorectal cancer screening would be beneficial for people living with HIV. Anyone know why I say with sufficient life expectancy? Why don't we just screen everyone? So typical person who's diagnosed with one of these cancers, if they only have a 2-year, let's say they only have a 2-year life expectancy, there's probably no point in knowing, if you're screening by definition means that you're asymptomatic. There's probably no point in knowing that, it's probably do more harm than good to know that you have that cancer, because you're going to be dying of something else anyway, and the cancer may never cause any kinds of problems. So typically, like for example, for colorectal cancer screening, the recommendation, not just for HIV infected, but for everyone, is that you only get screened if you have at least a 10-year life expectancy. Because it takes, it's so slow growing, it takes long to develop. Okay, so then more research is needed to determine the benefits versus harms for other screening. So one is anal cancer, which could be very important. Because as I showed, the risk for anal cancer is very high. But we don't know if cytology or high-resolution anoscopy really does any good. You probably haven't, in EPI1, you probably haven't gotten to screening yet. Am I right about that? You talked about screening in EPI1? Any of you taking EPI1? A little bit. But you'll get it, those of you who take EPI2, you'll learn fairly thoroughly about screening. And what a lot of people don't appreciate is that, the intuition would be, okay, why not screen? If you could find the cancer early, you might as well do it. But it turns out that there are a lot of harms to screening that aren't generally appreciated. The most important of which is probably if there are a lot of false positives. So people who have false positives go on to get, now they're in the medical system, they get more tests which are invasive, then those tests could harm them. If they're false positives, they had nothing to worry about in the first place, but they're having all these potential harms. So in any event, it's important for any screening to show that there's more benefit than harm. And for HIV-infected patients, it's actually not known for anal cancer. For lung cancer, there's a big push on now to screen smokers using low-dose CT. Whether that would also be beneficial, you have to do a different kind of benefit versus harm analysis in HIV-infected patients because there are particularities to that. And actually, I have a colleague who got an R01 grant who's doing that kind of analysis right now. Liver cancer, there's no, a lot of people who do liver cancer really push screening, but there's really no evidence at this point that it does any good. It might do, I'm not saying it doesn't, it might, but we don't know one way or the other, even in people who are HIV uninfected. But it's an important issue in the HIV infected because liver cancer is becoming more and more important due to high prevalence of co-infection with HCV and HBV. It's becoming more and more important in the HIV population. So this is an important area of research. All right. So then to summarize, going back to my early slide that I keep showing, cancer is a major cause of morbidity and mortality in people living with HIV/AIDS. They have an elevated risk for many cancer types, especially those with a viral etiology. And that's due to HIV infection itself and to a high prevalence of non-HIV cancer risk factors. Cancer prevention among people living with HIV/AIDS includes almost certainly early ART, reduction in prevalence of non-HIV cancer risk factors, and screening for selected cancer types. And there's a lot of important both public health practice work and research that needs to be done, I think, in this area. So, I'll take any questions. Okay, Elaine?
Well, actually, this is just a comment, and it's about smoking again, and I realize there's a lot of focus on that. But it happens at the, I'm serving on the Connecticut Tobacco Settlement Board, and I mention this because we recommended funding smoking cessation, relapse prevention in the correctional system, and there's a very innovative program going on now that's been funded through the board, and we did a survey in the number of facilities of prevalence, and the smoking prevalence in this population was like 70 to 90% in these facilities. And they went in, when they went into the facilities, they were smokers.
Okay.
So the program is designed to get, but I'm just curious that there has to be overlap.
Mm-hmm.
It would be like,
Right.
and it's another way to do more focused work around.
To find populations with high prevalence, right? So, yeah. Oh.
When you were doing your analyses of these sort of questions, you were looking at viral RNA doses and have species of interaction between those two.
It's a good question. We're good. Yeah, we will. No, we didn't do it. I was thinking that when I was presenting this, we really should look at the interaction, right?
So, Rob, you presented the kind of interesting findings in that Cohort study, the Cohort study,
The NA Accord, yeah.
Cohort study. So, the finding with composite sarcoma. So, two questions. One is, what is the incubation period of composite sarcoma? Second of all, how did you choose that 6-month lag?
Okay, good question. So the incubation period, I don't think that's, so it's hard to define the incubation period because, I mean, once you're infected with the virus, you know, a lot of people are infected their whole life and they don't develop Kaposi sarcoma. So, I mean, that's an interaction, right? You know, if you don't have Kaposi, if you're not infected with the virus, it doesn't matter how low your CD4 count goes or your HIV RNA, how high it goes, you're not going to develop Kaposi sarcoma. The other hand, if you're infected with the virus, but your immune system remains strong, you're not going to develop it. It's only the interaction. But it's hard to define like what is, but the way we picked the 6-month, actually, I didn't show this, but we looked at different lags. We looked at 6 months, 12 months, 24 months, 48 months, and that was the best one. That's the one that was most predictive. It was the best model.
So the idea would be that there's some immune signaling, some biological cause or process that happens 6 months before, not 9 months or 12 months, that is keeping signaling.
Yeah, so, right. So it's probably more complicated. So this is kind of work in progress. So what we're studying what we're looking at right now is, I'll just talk about CD4, but we're looking at the same thing with the viral load. We're looking at the slope of the change. We want to see if a rapid decline, you know, is an independent predictor. If you have the slope plus the 6-month lag in the model. And then we're looking at the proportion of time below a threshold. So let's say over the past 4 years. Yeah, that's right. And so we want to see which of, then put all that together and figure out what's, yeah, how much is cumulative, how much, you know, is the recent, what's most important. Yeah. Okay. So it's 1 o'clock. I don't want to keep people past.